Okay, well, I'm just going to start on time to make sure we keep to time. I'm Julian Robinson, and I'm giving this talk, and I'm really talking about NST and CTG, which is cardiotopogram, non-stress test, and fetal Dopplers, plus la différence, plus la même chose. And the reason I picked this title is this is actually a talk I've given a good few times, and it's usually received well because it's about fetal physiology and in particular placental dysfunction, both in the antenatal period and on labor and delivery. And really why I give this talk is to give an insight into the fetal physiology. And when I refer to la même chose, it's basically the same physiology in both technologies. I really like this quote because I think it shows the really dramatic difference between the fetus and the neonate. This was by Joseph Barcroft, who's a fetal physiologist in Cambridge in the UK in the sort of like late 1800s to up to the Second World War period. And he made this statement that the neonate's first breath is the last dying gasp of the fetus. And I think it really outlines the very different physiology between the neonate and the fetus. And the aim of this talk is basically to prevent the birth of acidotic babies by the accurate diagnosis of fetal asphyxia from uteroplacental insufficiency. We basically have a number of technologies and tests that we use looking for placental insufficiency. I've outlined them here. They tend to come with different optimal times for use in the antenatal period or on labor and delivery. And I always like this little ditty that I got from Kurt Decker in Germany. It's the fetal prayer. While we're here, I am a fetus in the womb. I fear that it may become my tomb. I hope my obstetrician hears me shout when it's time to get me out. And what is going to give the shout for us is going to be one of these technologies. And I will go through them, each one showing their uses. And hopefully when we get to Dopplers and NSTs, showing how they're directly reflecting the fetal physiology and giving a window into what is actually happening with acid-base balance. And we can manage the pregnancy based on science rather than test a little rule or heuristics for test interpretation, which is often what happens in this day and age. We follow the babies through the antenatal period with ultrasound. We're basically looking at the estimated fetal weight or the abdominal circumference, and we are labeling anyone who's under the 10th percentile as potentially being fetally growth restricted and therefore at risk for placental dysfunction. Actually, about 70% of those babies, there's 1 in 10 babies get labeled. Obviously, 1 in 10 babies doesn't have a problem, and 70% are just constitutionally small with completely normal placental function. The placental issues can be identified through the umbilical artery Doppler velocimetry. And if we identify reduced diastolic flow, we know the placenta is increased resistance and therefore a dysfunctional unit. And then we have the option of either monitoring the fetus directly with a combination of Dopplers, middle cerebral artery, ductus venosus, inferior vena cava, and the umbilical vein. Or as what happens practically is we often use the BPP umbilical artery Dopplers and the NST, as this is just an efficient way of getting to the same end result without needing so much time and technology. And we do also have amniotic fluid volume changes, but these tend to happen very late in the sequence of placental dysfunction. There are a lot of Dopplers that we can study from the maternal uterine artery through all of the fetal Dopplers that I've listed here. And what we're really doing is getting a window into the fetal circulation. And it's very important. This is probably, to me, my favorite or most important slide of the talk, that we understand what goes on with the fetal circulation. And basically what happened is the blood comes in from the placenta through the umbilical vein. And so the oxygenated blood, which is going to be red in this case, I'll go with the pointer, the oxygenated blood is coming up here. And what actually happens, as it's been shown, is that there is laminar flow with the oxygenated blood coming into the ductus venosus through the IVC here. And what happens is that most oxygenated blood goes up the medial aspect of the IVC. So there's laminar flow with less oxygenated on the outside, more oxygenated in the inside. And that means when this blood goes into the right atrium, it preferentially goes through to the left atrium, so that the left ventricle is actually the highest oxygenated blood, which is then driven up through the aorta and to the brachiocephalix, to the brain. So the fetal circulation is very different from the adult circulation, with the left side of the heart really supplying the upper limbs and brain, with the right side of the heart supplying the main corpus of the body, with the more oxygenated blood going to the brain for obvious reasons. And that's the basis of the system, and why when we study with Dopplers, as you can see, we can get an insight into the oxygenation of the baby. These are the different Dopplers. I've just put them up, showing the changes that will come over time. And basically there tends to be a sequence with usually the umbilical artery being affected first, because that declares that the placenta actually has a problem. Then the baby goes through a sequence of reflexes with early preferential flow through the MCA, which becomes apparent as increased diastolic flow. And then the ductus venosus late in the series developing abnormal flow because of the hypoxic state of the baby. And I'll go into that in a little bit more detail in a minute. So when we study the umbilical artery, we are really studying the placenta and the placental function to discern between those babies that have a normal placenta and those who don't. The abnormal placenta, classically the preeclamptic placenta, will have narrow vessels, less vessels. It'll be a much higher resistance unit, and we can see that develop as we get decreasing diastolic flow, beautiful normal diastolic flow, decreasing, becoming absent, and eventually becoming intermittently reversed, then reversed. And we know when we get to this state of completely reversed, that the baby is highly likely to be hypoxic already. So once we start to get decreased diastolic flow, we then switch our attention to the baby. The Dopplers that are most diagnostic of a problem in the end state are the ductus venosus. And you can see this is the ductus venosus. What happens here is you have the systolic filling, and this is the S wave, the diastolic filling, which is early passive filling in diastole, which gives increased flow. And then this last wave here is the atrial contraction, or the atrial kick, which kicks the blood into the right ventricle to top up the ventricle before it empties. As the baby becomes increasingly hypoxic, you'll find that there's decreased elasticity and increased resistance in that right ventricle, and you'll see the wave change in stepwise fashion as outlined here, with gradually the atrial contraction, or the A wave, decreasing as the heart is more and more inelastic, until eventually you get backwards flow. As the atrium contracts, the blood is actually pushed backwards into the atrium, and then this is transmitted back through the IVC, through the umbilical vein, and actually can be picked up in both of those vessels, as well as increased pulsatility or notching, as in the state of the umbilical vein. So what I've done there is just outlined the changes in physiology that happen through the increasing stages of placental dysfunction and how they can be detected antenatally. And now I'm just going to switch gears and go into fetal heart rate tracing, or the NST, and classically in the setting of labor and delivery. And I'm talking about it in labor and delivery because this is the area where we most frequently encounter problems, and classically because there's increased stress on the baby because of the uterine contractions and compression of the placenta, and the increased incidence of hypoxia and asphyxia. Bringing a little drama in here, because I always find on labor and delivery the added pressure is the passage of time and the distractions of time. This is a slide from Willie Decker's La Traviata, and I always like it because I think it casts the drama that we get in L&D, where it's basically, this is Traviata here, and it's a race against the clock, often with an audience, and unfortunately often an audience of lawyers. I'm going to talk about fetal heart rate monitoring. It was introduced more than 50 years ago now. It got introduced in a very interesting fashion, and it would not get introduced in today's world of scientific rigor and the FDA and technological approach. It was introduced clinically very soon after its inception. It was introduced without a large body of research, without pre-market testing, and without an instruction manual. I'm very aware. I had an attending very early in my career who could remember the first day they had fetal monitoring in L&D, and he described it as being a crazy situation where the day before they did about 1 cesarean section, then they got their new NST machine in labor and delivery, and they did 7 sections the first day they had it. And so we're now going back in retrospect, and we're introducing our instruction manuals, which in this day and age are really a series of heuristics, but we'll go through some data now. This is my experience in OB quality and safety at a local hospital. It was 1 year, I just took a year when I first started to put this lecture together, and we had 10 cases of Apgar's lesson 4 in that case. All of them were category 2 tracings, all of them were followed for too long, and they all deteriorated quickly, ending with a bradycardia. And in every single case, the common factor we found was a false reassurance from normal variability. And this was a very common feature through the fetal heart tracings. So going through the charts of these tracings, here are some of the comments that I took out. What was giving the providers or the carers increased confidence or allowing them to go on too long with the trace? And these are the typical comments you get. Increasing baseline, decelerations noted, but reassurance taken from normal variability. Variables throughout with occasional lates, rising baseline, always normal variability. Occasional tachysystole, short bradycardias, early and late decelerations with a rising baseline, but always normal variability. And in some, I would find this statement, normal variability precludes asphyxia. So basically in all of these cases, there was a lot of reassurance being taken through from the variability. So we'll come back to that later. I'm just going to go through the different types of accelerations and decelerations. I'm not going to spend a lot of time on this because I think this is pretty basic information for us. But accelerations, they're basically classically sympathetic activity, fetal movement. Usually they're either spontaneous or a response to either noise, stimulus, either touch or scalp stimulation. They're reassuring, and the reason they exist is that the fetal heart doesn't obey Starling's law. It's a chronotropic rather than an inotropic organ, and that's why the fetal heart rate is a particular use just for the fetus. Where in an adult, we will increase our cardiac output as we get increasing stretch of the ventricles. In the fetus, that doesn't happen, and its only way of increasing cardiac output is by rate, and that is why we get these very often variability and these accelerations associated with movement. If this was an adult, we wouldn't increase our pulse with such small excursions of movement. Then we have the early deceleration. This is quite simply a vagal response. It's if you get increased cranial pressure, it's a real thing. There are baroreceptors within the intracranial contents. And when you stimulate those baroreceptors, you get an immediate vagal response. It's thought in evolution that this comes from seals and diving mammals, when perhaps man was aquatic. But as you go down to deep pressures, this is how seals and sea lions, etc., slow their heart rate. It's a vagal response from the increasing pressure experienced through the baroreceptors in their head. It was actually demonstrated when they first introduced the fetal heart trace at Yale University, where Ed Hahn, who came along with the technology, actually went to the NICU with rubber bands and showing by putting the rubber bands around the baby's heads and tightening, you could induce an iatrogenic or deceleration such as this. It's a normal evolutionary thing. Then we have the variable deceleration, and it goes through, there's the classic M wave. I just go through the sequence here to show the theory behind it. So basically you get umbilical cord compression, and the vein occurs first. And when you get the vein being closed first, you get transient hypovolemia. And in some cases, there's actually one, if I don't know, I can just move me here. You'll see here, sometimes you get a little uplift of rate just before the deceleration in response to that hypovolemia. But then you get compression of the artery, you get increased pressure, and that increased pressure, blood pressure, is picked up by the aortic and carotid baroreceptors. And again, you have the vagal stimulation leading to this big deceleration. It's a vagal response, and therefore it's immediate. And once you get alleviation of the pressure, you often get this little acceleration at the end as there's been transient minor acidemia, and there's a reflex tachycardic response to that chemoreceptor response. So you get this classic M wave, which is your variable deceleration from umbilical cord compression. Then you have late decelerations, and there are lates and there are lates. And I've given two examples here, and they're very obviously different. They're both obviously very late, with the disconnection between the peak and the trough, between the contraction and the deceleration. And I'll deal with each of those in particularly. Back to Joseph Barcroft, who gave that statement at the beginning of the talk about the first neonatal breath being the dying gasp of the last gasp of the dying fetus. He did a lot of research into late decelerations and basically studied the response of fetal lambs to umbilical cord compression with and without an intact vagus nerve. And he found with late decelerations, these happened without an intact vagus nerve. And he came to the assumption that they were therefore a non-vagal response, and they were a delayed response due to a chemoreceptor mechanism. So let's go into that in the diagnosis of the late deceleration in detail. This is the work of Julian Parrer from San Francisco in the 80s. And what he did was he took pregnant ewes and he basically put in multiple catheters and flow transducers with a Fogarty balloon catheter in the distal aorta, so that when he blew up the Fogarty balloon, he could occlude the blood flow to the uterus and therefore mimic a uterine contraction. And the uterine contractions that humans get are peculiar to humans. In all the other mammals, they tend to be much more low amplitude and longer and not as dramatic. And so the Fogarty balloon was to mimic the human uterine contraction. He basically wired and tubed and put this all together to have a model so he could monitor what happens to blood flow and acid-gas balance and blood pressures during the uterine contraction. And this is what he found. He blew up his balloon, and when he blew up his balloon, you would get occlusion of the uterine blood flow, which led to a drop in the blood pressure, which you would expect, and eventually led to a delayed fetal heart rate reaction. Here's your deceleration, but interestingly, there was no change in the fetal arterial pressure or the umbilical blood flow. So why is the late? It's late because it's a chemoreceptor mechanism where the chemoreceptors detect the transient acidemia. The transient acidemia, it's actually physiological. All of our 100-meter and 200-meter sprinters and modern athletes will actually hold their breath and rely on anaerobic respiration. They do get acidotic, but they're obviously in good health. When you get acidotic, you have this hindquarter brain sparing reflex where you cut off the blood supply to your periphery to keep your brain preferentially supplied, and that causes central hypertension. And when you have the central hypertension with the carotid and the aortic baroreceptors, you get a baroreceptor response and a vagal response, and that's what leads to the deceleration. So it's this two-step effect of first acidemia and then pressure that makes for the timing of the late deceleration being late. So then he looked at manipulating this deceleration and found that if you give atropine, i.e. blocking the vagal part of it, you could block the deceleration. And when you block the deceleration, you'd actually get an acceleration, and that in turn can be blocked with a propranolol. because this was sympathetic activity coming from the stress response from the adrenals and the noradrenaline. So therefore, it came to the conclusion that the occurrence of a late deceleration is mediated by the vagal nerve in the presence of beta-adrenergic activity. And the problem with this was that the sheep were not hypoxic. This was basically a physiological late deceleration. And that's at first when I talk about there being lates and lates. These are the lates that we often see appearing that are very particular in nature, but are purely a physiological response to a transient insult in a healthy fetus or baby. And these in themselves do not necessarily indicate an ill baby. So then he repeated the series of experiments, but this time he did it with hypoxic sheep. He actually made the ewes hypoxic, did the same experiment, and hey presto, found that he still got a late deceleration, but it was not abrogated with atropine. And these lates are the lates due to the hypoxic myocardial depression. It's the same mechanism that I was showing you earlier with the Dopplers in the ductus venosus abnormal flows, when you get the A wave that decreases and then becomes reversed because of the increased inelasticity or stiffness of the heart. This is the same hypoxic mechanism, but we're just picking it up with the fetal heart rate, with the late deceleration. In this case, again late, but in this case you can see there is a dip in the fetal arterial pressure, and the blood flow in the umbilical vein or umbilical artery goes down because the myocardium is actually sick and ineffective. So this is a very different mechanism. This is the hypoxic one. It's not blocked with atropine, and that's because it's in the hypoxic fetus, and the heart is not functioning normally because it is myocardial hypoxic depression. And this is, oh, I thought I had the other one there, I didn't. And this is the classic late deceleration you get, which we had in that first late deceleration picture, where the late tends to be very subtle and often in a flat non-reactive tracing. So putting together this fetal heart rate patterns, we can put together our heuristic approach of early don't matter. Variables reflect cord compression, but if they're deep and repetitive, sooner or later they will lead to fetal hypoxia. Lates can be vaguely mediated and physiological and normal, but if they're deep and repetitive, sooner or later they will lead to fetal hypoxia. And pathological lates are due to fetal hypoxia and are due to hypoxic myocardial suppression. And those are the ones we want to deliver the baby at or before. And this is that classic pathological late, these much more subtle, nuanced decelerations. And these are the real bad actors that we're looking for in the management of labor and delivery. So they're all the same thing. Pathological lates, abnormal ductus venosus A wave, pulsatile venal cable waveform, umbilical vein notching. They're all the same thing through the same mechanism. We're just detecting them through different technologies. That we're using the tests to be a window into fetal physiology. So the big message I always want to give in this, people tend to oversimplify the heuristics, and they look at the trace and they classify them as variable, especially deeper variables, and they think they're just variables, they're fine. But to me, interpreting the fetal heart trace is a continuous process, and when you see them, you shouldn't just think, oh, this is fine. You should make a mental note. But if these persist, especially physiological lates, they will sooner or later become hypoxic. So yet again, I'm sure for everybody, we'll go back to the fetal heart categorization. Category 1, normal. Category 2, intermediate. What I would call no man's land. And category 3. I'm not going to spend a lot of time in this because I'm sure everybody knows them through multiple repetitions now. But category 1, basically normal variability, no late or decelerations, and early decelerations may be present or absent. Accelerations may be present or absent. So basically, normal variability, no late or variable decelerations. Category 3 is obviously abnormal, absent variability plus decelerations or abnormal patterns such as bradycardia or sinusoidal pattern. And category 2 is basically everything else, not 1 and not 3. And actually, category 2 is not predictive of fetal acid-base balance. 80% of traces have regions of category 2. And this is our variability. You can see it there. We usually take more than 2 cycles per minute. And in modern obstetrics, we have no distinction between short and long-term variability. In essence, the category system is driven by variability. You can have variable decelerations, late decelerations, and no accelerations as long as there's variability presence. Once variability is lost, as long as there are associated abnormalities, it's category 3, and prompt delivery is indicated. But so therefore, to me, the secret of surviving and thriving with a category 2 tracing is not to stay with category 2 for too long. And I saw repetitively in the world of quality and safety in obstetrics, this is the real trap that frequently or not infrequently people fall into. For whatever reason, they end up following a category 2 tracing for too long. Variability is the chronotopic tone between the sympathetic and parasympathetic systems. When you look at those sort of experiments I showed you from Power and Bancroft and look for the equivalent with variability, there aren't any. And when we ask ourselves how long a period of reassurance does normal variability guarantee, the answer is no one knows. It depends on what predates it. So going back to the concept of time, I'll take you through a few traces just to make my point. This is a clinical case, it was a real case. 20-year-old G1P1 presents in labor, 37 weeks, 480-1. Nothing dramatic in the history, led to prenatal care, but nothing too concerning. Early on in the tracing, this is the tracing, we had this episode early on. There's a plan in the notes, 4 centimeters dilatation, epidural placed, attendings were planned for primary C-section if the fetal heart rate does not improve or worsens. It improves slightly, we've got accelerations there, we've got lates, but they do look like those physiological lates. Time begins to pass by. There is a fetal tachycardia, but it improves with intravenous hydration. We're doing the usual position changes for decelerations, continuing expectant management. There's a shift change. We do make progress. We're now 6 and 100. And there's a note in the chart that there's good variability, which precludes fetal acidemia. Position continues to be changing, and the trace continues to be monitored with the attending. And the trace continues to have lates. It's got good variability. And basically what's happening in this case, it's the classic case where we're making progress. The cervix is now 8. And we have what I've called mission creep, that early on in the tracing, we were already beginning to think about a C-section. The head was -1. This is a nullip. To me, that's a real warning sign. Why isn't the head engaged with a nullip? A sign of a high head. And basically, the tracing continues to deteriorate, and you continue to get what I call mission creep, as they get pulled into the management with the changing progression, a deteriorating trace, time passing without people realizing, and false reassurance being taken for by things like acceleration with scalp stimulation. And in the end, we have a crash cesarean section. This is interesting to me because I don't know if people see these spikes here. I don't know how true it is, but I've heard it said that these are actually little arrhythmias due to hypoxia when it's with a fetal scalp clip, as in the case here in the hypoxic baby. But you can now see a very abnormal trace. And the baby gets delivered, and basically in panic. This was a baby, as you can see from the delivery note, I won't go through it, but you can see by this time, everybody realizes the time has passed, they've ended up in a very bad situation, and there's basically a panic-stricken delivery. And I think actually the baby in this case ended up with a broken arm. And this, when you look back on it, had all of the usual things you can look for that were not good signs. Dollop, larger baby, high station, slow progression, but she did keep progressing slowly. Another case I just thought I'd bring in to give the same sort of lessons, the same sort of story. You can see here, beautiful trace. It's an induction of labor. Trace continues to look beautiful, but time passes. And you can see that the trace changes. Never particularly abnormal, but you can see this is what we get to, this type trace. But remember what it was like. This is what it looked coming in. And basically it's a long induction, prolonged rupture of membranes, many examinations, slow progress, but it continues, but gradually we get a tachycardia, time passes, the tachycardia continues, but it's attributed to chorioamnionitis, and the variability is reassuring, and then we get to fully dilated, but then we're too late, as you can see from the trace now. And this actually ended up being a demise. And in both of these cases, great reassurance was taken from the variability. And there was what I would call mission creep, when in both cases there was a plan for delivery that didn't get followed, early delivery if the trace wasn't reassuring. And in both cases, they got sucked into the management due to a number of reasons, the classic ones of which are provider solitude, night shift, high BMI, no one's keen to do a cesarean section in a very high BMI case, enough progress to justify continuation, and then response to treatments and resuscitations of things like chorioamnionitis and position changes. So going to our recommendations from ACOG that were written up in the American Journal on the how should we be managing these category 2 fetal heart traces to have a standardization of care. It's not actually a pretty simple algorithm was put together, and this is the algorithm here. And you can see that what it's based on is the presence of good variability or moderate variability and accelerations. And when you go down each of these pathways, you will see that it comes down to very much the weakness is what happens if you're making progress. Because as long as you're making progress and you've got moderate variability, the answer is to observe rather than to deliver. What the paper doesn't address is what is normal progress. To me, where I was originally trained, we would just do vaginal examinations every 4 hours. In the active management of labor, normal progressions 1 centimeter an hour. And this paper doesn't stipulate, but progress, there's a very wide spectrum into what progress is or what is adequate progress. And you can run the risk of the progress not being adequate enough and the baby became hypoxic. This whole protocol is basically based on expert opinion. A group of experts sitting around a table basically coming up with a recommendation. It's not based on science. And to review again in variability, the variability in the fetal heart trace is actually caused by the interplay between the sympathetic and the parasympathetic systems, the hypothalamus and the brainstem. So loss of variability from utero-placental insufficiency is actually due to a hypoxic injury to the hypothalamus and brainstem. So the point is, when you have variability, it doesn't tell you how much time you have left. You can see the progression through accelerations, variable decelerations, physiological lates, and then pathological lates. But with variability, it's either there or it isn't. And when it isn't there, it's too late. And even according to that expert opinion statement, it makes a statement that intermediate variability is not predictive of fetal acid-base balance or status, but it has become a mainstay in our heuristics of the management. And so for me, I worry about it being a little bit of a modern myth. So my conclusions are basically both NSTs and Dopplers are windows into fetal physiology. Both pathological late decelerations and abnormal ductus venosus A waves are signs of fetal myocardial ischemia. The presence of a normal variability suggests that the hypothalamus and brainstem are not completely non-functional, but nothing else. It is therefore best to manage the whole case, including events over time, rather than just a test in the moment, taking together the whole picture and all the clinical inputs and using the whole of the testing information rather than a snapshot in time. So that is the last slide. How did we do here now? Did I hit skip?
And if anyone has any questions, you can put them in the chat. Just type them into the Q&A.
Can I ask a question?
Sure.
Okay, Julian, thank you very much for a truly excellent talk and for the physiology of fetal monitoring. I think it's extremely important because, sorry, I'm going to spend 1 minute. Okay?
Yeah, no, go ahead.
Because I think it's a lost art and nobody's looking at the science anymore. Everybody thinks in terms of categories, which is the worst thing that could have ever happened. When I trained, when you practiced, we did scalp sampling, and therefore we're able to see the correlation between fetal heart rate patterns. I would do, when I worked in England, I would do probably 15 scalp samples every time I was on. So you can see the correlation between the fetal heart rate tracing and the acid-base status. Now, a few observations. The first is that Ed Horn, when he invented fetal heart rate monitoring, actually described these patterns that we miss very often now. And you did mention something, the tachycardia that takes place. In his description of the fetus that was becoming acidotic, he described the tachycardia, then the loss of variability, the deceleration, and then if you didn't recognize that, you have the terminal bradycardia. And what is happening now is very often we miss this because they say, oh, there's variability, and you have the tachycardic fetus. So thank you very much for pointing that out. And I think it's something that's not observed. You also made another observation about the tendency for people to say, oh, the patient is making progress. It doesn't matter whether the patient is making progress or not. If the fetus or baby is in trouble, you need to deliver the baby. And there is a concept in aviation that leads to plane crashes. And it's exactly the same thing. It's called get there-itis, where the pilot knows that there's a problem, whether with the runway, but they're so fixed on the mission of getting there. So I think the points you raised are very valid, and I think you need to preach more to obstetricians so that hopefully we'll make those changes. Finally, talking about the categories, Julian Parra, I knew him, he was called Bill, unfortunately he died a few years ago. But when they did the NICHD categories, they actually argued passionately for 5 categories, as you know. And it was like in the days when they had a pap smear and there was ASCAS, it was ASCAS favor malignancy, ASCAS favor something else. And unfortunately now everybody looks at this so-called category 2 fetal heart rate tracing, and there is no distinction between the pathologic ones and the totally normal ones. I've spoken a bit, but I just want your viewpoints about these 3 or 4 things I've spoken about. A, the concept that the patient is making progress and not therefore, regardless of the fetal heart rate monitoring, nobody's paying attention. B, the significance of the tachycardia, which I think from the cases you showed, they all became tachycardic and people thought they were okay. And finally, whether this concept of category 2 fetal heart rate monitoring, where nobody has any idea what they're thinking about, is actually in service.
Okay, I'll address this, then we've got another question from Ingrid. So trying to address all of those points.
I know, right?
So first of all, I agree with well, first of all, going back to front, I think the variability or the simplicity of the category system, and particularly the leaning towards the reliance on variability, which the system itself says is not predictive, has been a very bad development, because I saw it develop with people I'd see it written in the notes, the classic statement, good variability, therefore asphyxia excluded, which is definitely not the case. So I think there has been an oversimplification, and there has been a reliance on these heuristics. You know, this means this, that means this, see this, do that, which is, again, oversimplified, and again, always ends up at the same point. If there's good variability, you don't have to worry. And a lot of the science slides I put in was to make the point that the science isn't there for the variability. It's not, it hasn't been to the same degree full of that elucid manifestation that you can go through with the sequence of the different types of decelerations. Variability just tells you your hypothalamus and your brainstem is working, and when it's not there, you've blown through to a very sick baby indeed. Tachycardia, I always remember in the statement, the tachycardia in the absence of a maternal fever is exceedingly concerning. Yeah. When you see the fever, and you can think of chorioanal amnionitis, but then you've got a limited time to treat it and get a resolution, because if it persists and if it basically wasn't there due to a fever, if it wasn't there due to a fever in the first place, it is a very concerning sign, because it is showing you that something is changing within the baby, that the baby is mounting a physiological response to. And I think that's the basic issue, that all of this whole area has been oversimplified, where it used to be a science that people spent a long time thinking about, learning about, and integrating many different information pieces into calculating what was going on, to basically this very simplistic management. I think the rationale behind the approach now is we have many different people interpreting these traces, and therefore we have to have a common mechanism that we all interpret them the same, and we've then consequently just ended up with a too simplistic a mechanism, which actually doesn't reflect the pathophysiology behind, or the understanding behind what is going on. I'm looking at Ingrid's question now, which is our learners seem to be getting so confused with the back and forth of the expert opinion, and we want to decrease the cesarean rate, prolong labour, but we shouldn't watch for too long. How can we teach this balance better? I don't know, Ingrid, but I can tell you, the back and forth is, to me, quite remarkable. And even when we're talking about time here, like, to me, I always take the example of a very simplistic approach that Richard Beard, when fetal scalp sampling first came along, it was introduced in Germany by, I think, Eric Salinger. But Richard Beard, when it first came out, basically just took a lot of scalp samples every hour through labours. In many cases, he just got a load of labouring women and did scalp samples on the hour, and showed that on average in the first stage of labour, the pH drops at an average of 0.01 every hour. And in the second stage, it drops at an average of 0.1 an hour. So there's your time scale right there on average. But you can see, particularly with the first stage, the timing isn't as important. But in the second stage, you can go from a normal pH to an abnormal pH in a very small number of hours. So I do think, to me, it's just the fact that our approach in the attempt to achieve a higher vaginal delivery rate has led to these much longer labours is very nonsensical. And if you actually look at the whole evolution of the management of labour over hundreds of years, you'll see the trend, particularly ending with the active management of labour, is shorter is better. And you see that now in modern practice with the extreme example of mainland Europe and France, where the second stages are very short, much shorter than what we use. And I've got to make the comment that when you practice in different settings and think what is so different about our setting, the answer you have to come up with is the epidurals. And basically, if you practice with a low epidural rate, I find it hard to believe, but the last time I looked, it's still only 27% in the UK. It's just impossible to have very long first and very impossible to have long second stages without epidurals. because the patients basically don't tolerate it. And therefore, I think that's a big part of what has got us to where it's got us today, this with the very, very high epidural rates. Not saying that's a bad thing, but I think if we need to keep an eye on how long we let the livers go on for. Feel free to comment, Yinka.
I agree with that. I mean, I think your lecture was incredible. Now, what do you think, though, about this issue that the category 2, you know, it's horrible hearing people say, what was the reason for delivery? Category 2 fetal heart rate racing, which basically doesn't mean anything. And so I think we are doing, it goes back to Ingrid, it kind of all ties in together that we simplified everything, and now it's like we prolong things and nobody's actually paying attention to what's going on. Don't you think we would be better off if there was some division of the category 2 so that you know what action to take? So for example, somebody who has a totally normal fetal heart rate tracing and has 1 or 2 variable decelerations, they'll say category 2. The one, it's interesting that bradycardia is not a category 2 fetal heart rate tracing. Without late decelerations, it's common. So I think the categorization now is a great disservice if people just think blindly category 2, which is a problem with the paper by Clark et al. You know, they say category 2, but what does that mean? 1 variable deceleration, no variability, and a normal fetal heart rate.
Yeah, no, I think our categorization of the fetal heart tracing has shown us that it's a failed experiment. I think the rationale behind it is to have a uniform way of interpreting the fetal heart tracing. I feel that the ultimate goal should be for us all to be able to interpret the fetal heart tracing accurately. And I think what we've got to where we are today is showing that the categorization approach it's meant to be a simplification. It's meant to lead to unification. It's certainly a simplification. It's an oversimplification. It has not led to unification. And the only way further is having people with a true understanding of what the physiological window is that we're getting into what is actually going on, and then integrating that into the clinical management of the case. And it's every aspect of it. I think you can see how management in labour and delivery has changed over many decades, that, you know, now all the patients get managed the same. There's no, you know, people don't look at the management of a labour ward board, where you look at the different patients, you pick the ones that are very unlikely to have problems, the ones that are less likely to have problems, and then where you're concerned you're going to end up in a bad place, and you tailor your management accordingly. I think that has all been lost. Seems a good place to finish.
Thank you very much. That was really amazing. Thank you.